It shows that higher buprenorphine doses are consistently associated with improvement in treatment retention. You don't want people to just come one time or two times. You want them to stay in treatment. There's no clear evidence actually identifying like a maximum effect or safe dose at the commonly imposed limits that we have. Dose caps persist despite changes in the opioid supply, including widespread of fentanyl exposure.
How do we know what the evidence is, understand what the policy is, and work towards changing that? But in the meantime, with each patient, meet them where they're at. Think about what we're actually doing.
Has there been like a change in the policy?
Buprenorphine is a partial opioid agonist, which means that essentially it's turning on the receptor. And the fact that it's partial, it's not turning it on like, let's say 100%, it's turning it on, let's say 50%. We should never be telling our patients what to do. We should be finding out what are we trying to help them with and create a goal that we can both align with. If they're not trying to do the same thing as you, then they seem like they're being non-compliant when really maybe you're not being compliant with what it is that they're trying to achieve.
We have a 38-year-old woman with severe opioid use related to fentanyl, and she presents for outpatient treatment. What clinical signs will suggest inadequate buprenorphine dosing? Hello and welcome to the Transformed Mind podcast. As you all know, this is the podcast where we're exploring the intersection between addiction, psychiatry, and transformative care. And as always, I'm your host, Dr. O. Each episode, we're taking a thoughtful, practical, and evidence look at how we can best improve psychiatric and addiction care in clinical settings and the communities that we work. If you're new here, here's the vibe. We have our host RX, where it's just me and you. We take different literature and we break it down. Then we have our expert RX, where we have experts like Dr. Drits, who are brilliant in their field. They have so much knowledge and expertise in what they're coming to teach us and a lot of experience. So we learn from that. We also have our special segment, which is the Live RX, where these are people that have lived it. They're experts in what they're telling us about and their experiences. And because they've lived it, they've survived it, and they're impacting lives. Today, I am so excited because we have a guest whom I'm a little biased because this is my own clinical supervisor and I've learned a lot from her. So I hope you all learned as well. Today, we're going to be exploring one of the most pressing issues in treating opioid use disorders. You know, you see it on the news, it's trending, the opioid crisis, overdose deaths, fentanyl. You see it everywhere. But when it comes to the people at the front lines, to the people that are experiencing it, there's one thing that impacts them. And that is the guidelines that has shaped how buprenorphine, which is a treatment we use, is actually dosed. So today, our conversation is going to be grounded in a 2023 narrative study by Grande and his colleagues. This was published in the Journal of Addiction Medicine, and basically they're critically examining the evidence behind those policies for the dosing limits that we have. So these are things I want you to look forward to. When we look at the study, we see there's evidence that suggests that dosing up to 32 milligrams per day may benefit patients. We also see how rigid dose limits actually affect patients and clinicians. And actionable insights for clinicians, trainees, policymakers, community members that may be listening, just navigating the opioid crisis. Joining us today, as I mentioned, Dr. Drits, who is my clinical supervisor, also my associate program director, and my vice chair of education. She wears a lot of many hats that involves training people like myself who work in the field, work with a multidisciplinary team of therapists, case management, a lot of people. So regardless of where you fall in the spectrum of clinical care or your life in general, there is something that's going to be there for you. Let me tell you a little bit about Dr. Drits. Dr. Drits received her Bachelor's of Science in Molecular Psychobiology from the State University of New York. She received her medical degree at Lake Erie College of Osteopathic Medicine at Seton Hill. She went on to do her general psychiatry residency at Staten Island University Hospital, which is part of Northwell Health, where she served as the chief resident. She completed her addiction psychiatry fellowship at New York University, after which she was recruited to return to SIUH, where she has been the associate chair of education and training, associate program director, and the director of the chemical dependency outpatient clinic. Her passion includes addressing stigma, patients with substance use disorder, physician wellness, and medical education. She has training in CBT, including CBT for insomnia, personality disorder, CTR, and incorporates mindfulness-based recovery and DBT. In her free time, her favorite pastime is spending time with her family, especially her daughter and son, and traveling. And they are so cute. So, welcome, Dr. Drits.
Thank you so much for having me.
Oh, I'm so excited. Guys, she worked. Mondays are very busy days, but she made time to come here. So I'm so grateful she's here and to tell us a little bit more about buprenorphine. So in this episode, we're exploring what the evidence actually shows. So sometimes when people make policies, there may not be much evidence to support it. And that's what this study is alluding to when you look at it. The initial policies that went into the dosing of buprenorphine didn't really have evidence to back it. So we have Dr. Drits here. And to set the stage, we're going to pull 3 evidence-based literatures from the study. So across the studies, it shows that higher buprenorphine doses are consistently associated with improvement in treatment retention, which is important because you don't want people to just come 1 time or 2 times. You want them to stay in treatment. The other thing the study also showed is that there's no clear evidence actually identifying like a maximum effect or safe dose at the commonly imposed limits that we have. So regardless of the policy we have and the limitations we have in how much we can give someone, there's not actually evidence for that. And sometimes it's annoying, for lack of a better word, when you're trying to prescribe and then there's all these warnings on, oh, you're giving too much to the patient. But I remember having a patient who it was just not enough for them. And they had just come from the emergency room. They needed a bridge. And they're calling like, I'm still in withdrawal. Like, I'm not doing well. And you have to prevent that. So sometimes you have to go based off how the patient is feeling and what's the safest thing for the person you're treating. The third thing is also dose caps persist despite changes in the opioid supply, including widespread of fentanyl exposure. So we have Dr. Drits here. And we just want to know first your general thoughts about the study. If there's anything else that you want to say prior to that about introducing yourself, if I left anything out before we get started, the floor is yours.
Thank you. Yeah, I think that the one thing I would just add to my history is that, again, I've been in Staten Island for a long time through training and seeing the opioid supply change and how it's impacted patients throughout my career and training, and seeing how much it's impacted Staten Island, which is really hit hard with the opioid epidemic. And I think it's really why I thought this paper was really important. I think exactly what you said. So often it's great that we're doing evidence-based medicine, and hopefully some policies do follow some evidence, but oftentimes there's a lag, is demonstrated here. When the original policies came out, the supply was just very different that they were addressing. And sometimes we need more faster response to what's actually happening, especially when something so life-threatening as fentanyl. So yeah, I think the most important piece is really exactly what you said. How do we know what the evidence is, understand what the policy is, and work towards changing that? But in the meantime, with each patient, meet them where they're at. Think about what we're actually doing. And as psychiatrists, especially as an addiction psychiatrist, I'm often doing things off label. I'm often pushing the limits. And as long as I can really demonstrate why I'm doing that and making sure I'm weighing the risks and benefits, I don't necessarily have to follow the guidelines to a T. That's part of the art of it. But like I said, there's challenges because sometimes I can't get it paid for, or the patient is having such a hard time. They're already battling their internalized stigma that they're having about having to be on some of these medications. And then they're going to the pharmacy and the pharmacist is telling them like, why are you taking so much? Or, their family members are telling them that. In some settings, you'll even have the counselors saying that. In some A meetings and in A meetings, they're saying, why are you on any medication? So there's a lot of challenges that we already have to overcome. But I think this is a really important topic for that reason.
Absolutely. And from what I'm hearing, it sounds like there's a lot of gaps even within our clinical community of the different scopes of practice and knowledge that we may have on the topic or the subject itself. And sometimes that can come at the detriment of the patient who is receiving the care. And I think that is what makes podcasts like this or educational platforms like this important, where everyone, regardless of what scope of practice you have, to learn something. So hopefully today, regardless of what place, and I keep saying that, where you fall in the spectrum of clinical practice, you get to learn something, whether you're sitting your trainee or you are the person that is having problems or suffering from opioid use disorders, or you are on buprenorphine or you have a family member, you can learn something from this. What the central gap the study identifies.
It's really the fact that the earlier trials and labeling was really underrepresenting people who had a higher opiate tolerance and didn't necessarily have fentanyl exposure.
Like you said, there's not fentanyl. So it's different, like based on what you're using, the different strands, how much you're using, all of that. And people are going to present with different symptoms. So that all of that was not accounted for when they came up with that. So now, has there been like a change in the policy?
So again, I think most people in the field and that will tell you that they use higher doses. I still just as of last week had patients insurance who would not cover more than 2 strips of 8 milligrams Suboxone, so a 16 milligram dose total. So those challenges are still there. But again, I would say most of my patients are over 68 milligrams. And I think most addiction psychiatrists that I know treat patients are in the higher range of 16 to 24.
Absolutely. Like, how do you think like the earlier trials actually shaped the dosing and like today, the norms and the assumptions that we have? How has that been shaped by those trials?
I think that essentially that a lot of the policies came into place based on the evidence that more than 16 milligrams wasn't necessarily beneficial. There's a lot of talk about ceiling effect, although maybe a little bit misunderstood, which you can talk about. And I think there's possibly some bias that probably because it's cheaper to pay for less as well. And, I think there is some focus on also and maybe rationalizing it after the fact of saying, oh, well, then you're preventing diversion and so on, which is another thing that we can talk about.
Absolutely. Like when you mention about like the cost and people not wanting to pay for it, it brings me to the thought of, if we treat people appropriately, are we not in the long run sort of saving money? It's like cost effective. We're saving lives, but we also save money. How much time someone may have to, go into the emergency room because they didn't have the appropriate treatment or a therapeutic dose of the medication, and how all of those can cost more for the insurance companies that are refusing to pay or declining to pay, the policymakers, and how much grants and funds they have to put into some of these programs. So I think sometimes like this study shows the importance of having results to back up what we're saying, because these are things we know, but sometimes unfortunately when we don't have the results and the evidence to show or prove, they don't really listen to us as much as they should be listening to us.
And I think this really holds true for other areas. So, as you know, a big thing of what I like to focus on with my patients is smoking cessation, because it's the thing that's most likely to kill them if they don't die of an overdose. And that is very true, where a lot of times I can't get NRT or other things for smoking cessation approved. And if you think about it, for the insurance company, it would save a lot of money if the patient would quit smoking. But it's not always the way that the policies work. This just, is more cost effective long term. They're thinking about the short term a lot of times.
Yeah. So I would hope, if there's any policymaker that ever comes across this, or someone in a decision making capacity can think this all of this through to see that maybe it can save more money in the long run. I wanted to talk a little bit about the pharmacology of buprenorphine and how that support like safety and higher doses.
Yeah, so buprenorphine is a partial opioid agonist, which means that essentially it's turning on the receptor, and the fact that it's partial, it's not turning it on like, let's say 100%, is turning it on, let's say 50%. And those numbers are not 100% accurate, but just to give an idea, versus the other opiates that people abuse or misuse, like heroin or fentanyl or oxys and all of those things, which are full agonists. There is some evidence that in general, the way that how much of an effect the medication has does have a ceiling effect, which means it becomes less likely to do certain things at past a certain dose. It's talked about a lot, but really what the evidence shows is that the ceiling effect is really most relevant for the respiratory depression that occurs with buprenorphine, and really is evidence of how safe of a medication it is. Concretely true that it doesn't have further benefits at the higher doses past that, because people will notice they're having less withdrawal symptoms, they're having less cravings, they're having more of a blocking effect, which means that if they were to use their primary opioid, they would not have as much of a euphoric effect, which can help someone stay in treatment.
Yeah. When I'm hearing you, what I'm hearing is that, it's safer to use beyond the ceiling effect that's come up. And it's because there's not a better understanding of what that truly means, or it was taken out of context of what it was really for. So when we think about the people that are taking like 32 or 24, would you say there's a higher risk for like respiratory depression compared to those that are taking like 16 or 8 or a lower dose?
No, there is. If you're just taking Suboxone, no. If you're just using buprenorphine, no. But there is some risk, like with a lot of other things, is if you're mixing with other sedative hypnotics, if you're alcohol involved, that there could be an increased risk. But again, what we find is that usually when people are in treatment, and we see this all the time with methadone, which is a full agonist and has a risk for respiratory depression, getting the person to the right dose, even if it seems high, is usually beneficial for most of their substance use, for their recovery, for their stability, and is usually safer for overall mortality than if you're at a lower dose, even if they are mixing other substances.
Yeah. And I think that's important to understand in general, that it's not, regardless of what the dose is, there's not like a risk associated. It's if there's not good psychoeducation. I think one thing that I have learned from you is actually the importance of harm reduction education for the patients that we care for, the people that we care for, telling them don't use alone, giving them a Narcan kit, making sure they have one at all times. So in cases that they may need it, or they are using their medications with other things, they have all these different things that can reduce their harm or their risk of any tragedy or adversity happening. So I think that's really important to sort of address. And thank you for telling us more about that. Why is treatment retention so important? Like, why is it such a critical outcome for the people we care for?
Two things. One is that we know from study that it really shows that decreases mortality when you're retaining people in treatment. I think the other big piece is that addiction is chronic relapsing remitting illness that, like other chronic relapsing remitting illnesses that have both a behavioral and physiological component, really responds well to when people are in treatment. And there's often a really high relapse rate to the acute illness when you're not treating it. So it holds true for hypertension and diabetes and asthma and addiction. So I think retaining patients really is just about the morbidity and mortality of how addiction impacts people.
Definitely. And I think not so long ago, one of the previous episodes, and we actually captured it, buprenorphine saves lives. And in this context, we're talking about pregnant women during pregnancy and the importance of being able to use that, because research shows it's actually effective. And one of the studies that I looked at in the past actually showed, because when you're talking about it's same as diabetes, hypertension, that the treatments that we have, they're actually more effective than the ones for diabetes. That's what the researchers show. So I'm not sure why sometimes there's so much stigma that comes with it, or people aren't using it, people aren't taking the medication. I personally have had patients who they don't want to take certain things. They don't want to take stimulants, they don't want to take Vivitrol, they don't want to take buprenorphine because they feel like every time they've gone to pick it up, it's just the way the person looked at me, the way the person spoke to me about it. Even if I went to pick it up the day before it was due because I had to go out of town, it's just all these little nuances and stigma that comes with it. Sometimes it's heartbreaking to see people go through that, especially when they're trying their best effort. So I love that you highlighted it's not just a behavioral issue, it's also a physiologic issue. And there's also this chronic relapse and a remittent. Like there's all these cycles that you're going through that sometimes people on the other end don't see, especially when they're not in the field. Do you feel like the dose affect patients exposed to fentanyl differently than other forms of opioids?
Yes, I typically find that both in the inductions and the maintenance doses of buprenorphine, they're just requiring higher amounts. And like I was saying, I mean, I almost have nobody at those lower levels anymore. I think most of my patients stabilize around 24. I don't think I have a ton that are over that, but I definitely feel like we're going in the 20 to 24 range.
Is it different when there's like adulteration?
Meaning with fentanyl, if they're not knowingly using fentanyl or
If there's like other adulterants that are there, let's say someone was also unknowingly got fentanyl with xylazine in it or with cocaine or something else, do you feel like the doses work differently for them, or if they're actively using more than just heroin or fentanyl, any opioid?
yeah, no one's using heroin anymore because no one can find heroin anymore. I don't know. Do I find there's a difference? The difference I find sometimes is if the patient comes in and they're saying, "Hey, I'm using fentanyl. I'm knowingly using fentanyl," and they're requiring sometimes higher doses, versus those who come in and they're using and they are, we're doing a urine drug screen. We're finding out there's fentanyl. We're letting them know. And maybe that's because they're not consistently using fentanyl. I feel like they sometimes require not as high doses. But again, it's small. I don't know if significant differences because those might stabilize in the 16 to 20 range versus the 24 or a little above range.
So, like, knowing all of these, what advice would you give clinicians that may have like institutional dose limits of how much they could prescribe? Because I know from different institutions have different policies outside of what the federal guidelines or anything can be.
Advocate to make changes. I think that, talk to the stakeholders to see where you can make those differences, bring up the evidence that we do have that, retention and higher doses do usually retain. If someone is literally telling you, I'm still having cravings, I'm still uncomfortable, they're very likely to relapse. The cravings are a major warning sign to the person and should be a warning sign to the person asking about them. So I think I would do everything you can. You can get creative. For example, that patient I mentioned with who was only getting 2 films a day covered by his insurance. We have the Bup AP program in New York that we can get coverage for if someone is not fully covered with their insurance. So you can look at what is available and try to get creative and then just, yeah, continue to advocate and be the squeaky wheel in your system to try to make changes.
That's not always easy, but I do second that as advocate because just you piling up that advocacy, eventually there's a little bit of shaking that happens and people start to think. Even though the change may not happen immediately, people may start to think about these things.
The one thing I think that also happens naturally and sometimes is good to bring up when you are doing that advocacy is that the substance use population talks and word of mouth is important in where they will seek treatment. So if your institution will not allow dosing that is effective, they will probably go elsewhere to seek treatment and find places where that will dose them appropriately. And sometimes it's appropriate to tell your patients, these are the limitations I'm working within, but I would really recommend this or that. Like I do that in my clinic where we don't have like buprenorphine LAIs. Some of my patients might need it. We would refer them somewhere else that does offer that.
Absolutely. And I will definitely take that advice, even in different areas of advocacy, is always bringing up what may be the most important outcome for whoever that stakeholder is that you're advocating to. Being an APD and an associate vice of education, how would you say trainees, because you work with a lot of trainees, how should trainees think about this dose and flexibility in their training? Sometimes we're a little bit scared because we're starting out, we don't know much about these things. So, how should we think about it?
I think the most important thing in training is to do the things you're scared of while you're in training and you have all the support of supervision and you have an attending that you can run anything by, and you should work out all your fears there. And that goes true not just for buprenorphine dosing, but all things you might be worried about. I think it's really important that again you think about, I think sometimes when you're more uncertain about something, you are more afraid to do something. So part of that really is educating yourself, asking the right questions, looking for resources like this podcast or whatever it might be to educate yourself, because we really have shown that the more education you have on something, the more you are likely to have less negative attitudes towards that thing and less fear in working with that thing. And I think the other thing that happens sometimes when people have less education on a topic is they are a little bit more concrete. So we see that with some other people within the field where they have less training or less clinical hours and they want to follow algorithms very carefully. And I think that's very dangerous because, again, it's nice that we have guidelines and so on, but we oftentimes have to go off the guideline where appropriate.
Absolutely. Speaking of guidelines, what are some of the, and people having some concrete ideas when they are, I don't want to say less trained, but when they're less educated about a subject? What would you say, or what are some myths that may be there about diversion and may influence like dose caps?
So again, I think that the idea of higher doses equal diversion in general is really not founded by the evidence. It really shows that diversion is usually motivated kind of by self-treatment of withdrawal, meaning that people who are they're diverting to are people who have literally sometimes not been able to get their Suboxone they need because of the policies we talked about, or they're trying to do their own harm reduction. They're trying to use less or less frequently. Sometimes because their supplies run out or their finances have run out and they're trying to taper off with, for withdrawals. Very rare that it's being diverted for people to get high on because there's just much more effective ways to get high, quite honestly, because it is a partial agonist. And so the thing that is concerning as far as diversion goes that we do educate patients about is making sure it is locked up if there's kids or teens or things of that nature in the home, because it can be dangerous if you're completely opiate naive and you get your hands on it. But if, as far as diversion in general within to the community and into people who might be interested in it, I think there's a lot more fear than there is danger.
Yeah, absolutely. Talking about harm reduction and stuff, I remember I did a study on harm reduction tools, like effective ones, and actually locking up your medications was one of the effective ways to reduce harms, especially when you have kids or minors that can be around and pick things up. Very important. Harm reduction coming up again. So definitely educating yourself and being able to educate the person that you're treating. It's important. So we have our case presentation segment where we're going to present a case to Dr. Drits, and she's going to help us analyze the case, which she does this all the time, probably so many times in a day, especially on Mondays, listening to all of us present our cases. So we have a 38-year-old woman with severe opioid use related to fentanyl, and she presents full outpatient treatment. She has repeatedly disengaged from care after being stabilized on 16 milligrams of Suboxone, reported ongoing cravings, withdrawal. She works full time and has flexibility for appointments and fears relapse. For our clinicians and trainees, what clinical signs will suggest inadequate buprenorphine dosing? So this is a question geared for trainees, but actually it also can apply to someone that's experiencing it because they can figure out, but mostly they know the best. what they're going through.
Yeah, no, sure. So I think that, yes, if they're having cravings, and like I said, cravings are often the first warning sign that patients will have. And definitely if they're having any withdrawal symptoms, I think that's really telling that the dose is inadequate. Obviously, other ways you would know if someone is being underdosed is if they're continuing to use. I think that's a big one. And then also if someone tells you that I take this Suboxone, it seems to be working, but then sometime, later in the day, it's really wearing off and that's where I'm struggling. That might mean their dose is not enough. And then if it's impacting their ability to do these things. So this patient seems to be working and maintaining a full-time job still, but if it starts impacting their job or their caregiving or whatever else they might be doing, that could be another sign.
Yeah. So, from what I'm hearing, correct me if I misunderstood or I'm wrong, but just knowing what the criteria for substance use actually is, the DSM criteria can help you figure out if someone is going through or if someone's being underdosed, because this withdrawal is significantly impacting their life, some aspect of their life, and they're going to let you know what they're going through. Like, they're going to have cravings, and all of these are symptoms that we're already looking for when we're diagnosing someone.
Don't be afraid to titrate above 16 milligrams. And, you monitor for things like, are they overly sedated, or are there other risk factors of some, like taking benzos or anything like that. But otherwise, you titrate up in the 24 to 32 range. The other things to consider is sometimes timing of dosing. Sometimes it can be helpful to split dosing. I typically like to dose buprenorphine once a day and give enough at that one dose. Number one, because in general, not for buprenorphine, but any medication, the more times a day you dose it, more likely you are to miss doses. And you want the medication level to be consistent. The other thing is, does buprenorphine affect the enamel of your teeth and cause dental issues? And so my theory is that if you're doing that less times a day, there may be less risk. But having said that, there are sometimes benefits for split dosing that can be relevant to patients. Like, for example, if they have chronic pain, the analgesics effects of buprenorphine only last 4 to 6 hours. So you might need to be dosing it 3, 4 times a day. And sometimes it's again, it's both physiological and behavioral. So sometimes for people, they just know that the evening times are more challenging for them. And it really helps them to know that they're going to be taking it at night. You move it to the nighttime, or maybe you split it so that they feel covered for the day. And then importantly, just that you're considering things like, just for the dosing, not just the timing, but that you think about LAIs and like things like Sublocade if it's really difficult for someone's schedule, and or just remembering to take it, that you keep in mind that's available. And then you really just work with the person. So instead of labeling things as non-compliant, you try to figure out what is not working in the plan and trying to figure out what would work better. Sometimes it really does impact what your work schedule is, what your caregiving abilities are, what when are you home, and when are you able to have access to your medication.
And just talking about dosing, side effects, compliance, what are some other side effects that, in your experience, have been challenging for patients that's influenced compliance?
I think a big part of what impacts is, number one, that like any medication, what is the benefit they're getting from it? They have to see it as something that is valuable to them and that it's working for them. And again, that's to go back where sometimes having an effective dose can be helpful. I've had people who are non-compliant because they're taking a little bit, or they're using it and they're giving themselves precipitated withdrawal because of when they're taking it. So I think it's about really making sure that you know what the person's goals are and talking about harm reduction. If their goal is not currently not to use, it may be a different medication, it might be a different dosing schedule, so on. And then as far as other things that sometimes impact it is, if, like I said, like, their own ability to get things. So a lot of times, patients, especially who've been on it for a long time and have a long period of stability, their most often cited reason for wanting to come off it or trying to taper themselves is exactly what you described before, where they're like, I'm terrified that I'm going to run out. I'm going to go into withdrawal because my pharmacy will be closed. I won't be able to get it, or my pharmacist will give me, a hard time picking it up, or because I have to travel and I won't be able to do it. So it's things of that nature as well.
Yeah. I think sometimes it's difficult for some of the people, and you can really see they're trying their best. So We, like you said, we have to work with them and we have to meet them halfway. How have you seen like shared decision making support retention?
I mean, I think that is literally the most important thing that we can do. I think that, again, I often, when working with residents, will hear them saying things like, the patient's not doing what I'm telling them, or they're not listening, and things of that nature, which I think is really important to reframe. Of most people, first of all, when they go to their doctor, don't do what their doctors tell them. But again, we should never be telling our patients what to do. We should be finding out what are we trying to help them with and create a goal that we can both align with. Because otherwise, that is often when you're having, again, that term of like non-compliant. If they're not trying to do the same thing as you, then they seem like they're being non-compliant when really maybe you're not being compliant with what it is that they're trying to achieve. So I think it's really making sure that you present options for people, like I said, with whether it's higher total doses or split the dosings or offering LEIs, and making sure that you really hear their concerns when they talk about side effects, that you don't dismiss them. You can say that's not typical for that medication, but if you're telling me you're taking that medication and that's happening, that's a real thing. So let's weigh the risks and benefits together and think about what we need to change. And then I think that you want to really focus on, and again, this maybe is somewhere where policy comes in, of really be having an accessible plan and working with them. So a lot of what I do with my patients is trying to figure out how to navigate them talking to their other physicians about the fact they're on Suboxone, when to, disclose it, when not to disclose it in other settings, how we're going to get it for them if they're going to be going on vacation. So it's a lot of me like counting on a calendar, being like, okay, you know what? I'll just send you a week. So that way, when I send you a month in a week, you'll be covered for your trip. And being really, really available. Having in my clinic, a lot of times what I'm working on is how do we get, no matter where the request for the medication's coming in, that it gets to me or, someone who can prescribe the medication. How do we cover, what do we do? How do you educate your patient? What do you do if you can't reach me?
There have been times where I'm messaging Dr. Drits late into the night asking for her to help me refill because as trainees, some medications you can't refill, especially for the people that have Medicaid. They need a Medicaid provider, and a lot of us are not. Even though the regulations, coming back to regulations, even though the regulations says that we should, and pharmacies should be dispensing when we prescribe them, they don't. This has been such a eye-opener and learning more about just the different ways that we can manage people, especially in a complex space such as buprenorphine and misuse and how people may be feeling. One thing that I think is a big misconception, even with policies literature that's come up, is the ceiling effect. Not to bother you or throw you under the bus, but if you could, in 3 to 5 minutes, if you could teach us like a mini course, if you were to teach anyone about the buprenorphine pharmacology, why the ceiling effect matters or why it doesn't, or just the meaning of it, what would you say?
Sure. So, like I mentioned, buprenorphine is a partial opiate agonist. So, meaning it activates that mu opioid receptor, but really only up to a point. And so, as you increase the dose, like some of the effects rise, but then plateau. And that's what we call a ceiling effect. Like I mentioned, the most important ceiling effect is really on that respiratory depression. And so, again, while buprenorphine, the respiratory depressant effect increases at low to moderate doses, that kind of levels off. And then taking more than that doesn't necessarily proportionally suppress the breathing. And so, it really gives the medication a wide safety margin. I think that, again, the important things is that the other piece that the ceiling dose applies to is the euphoric effects. So that's why it is less euphoric, less misused, and is really a good treatment for opioid disorder. Where we don't find that there's strictly like capped to clinical benefits is things like cravings and withdrawal suppression and the blocking effect. That is, like I mentioned before, where it blocks the effects of other opiates should somebody have a slip or use. And so, yeah, I think why, it can really be effective at some of those higher doses that we talked about.
So, here are some key takeaways that I've picked up throughout this. Is that higher individualized dosing actually improves retention. and there's evidence to support that. Making sure that you are caring for the patient, meeting them where they're at, and you're supporting them well. If you're a student, this is your chance to learn more about buprenorphine, what the pharmacology is, how we're using it in clinical practice, and what the evidence actually says. If you're a policymaker, this is your chance to actually, regardless of what in the healthcare field or in general, anything in the society that you're putting forth, actually making sure there's evidence that support it. And the evidence is generalizable, meaning it can be applicable for everyone that has that issue, that has that problem is affected. So we don't have problems like this where people are getting subtherapeutic treatment. So this is my way of advocating for better care in general, psychiatrically, and addiction as well. So for the people in the general public that may be listening, we do have treatment that works, and we do have doctors, clinicians, therapists, people that are available and want to help and want to meet you where you're at and not impose on you, not judge you, any of that. So when you need the help, please seek out, because there are people that are ready to help you. So thank you all for coming. Thank you for listening. We are so happy that you come every other week to learn more with us. And we're so grateful for Dr. Drits for coming in and teaching us after a long day of work. We appreciate you. And as always, stay ready, stay aware, and stay grounded.